I'm Yasser Al-Sherbini. I'm an immunologist. I'm originally a medic, and I'm a professor of clinical pathology at Mansoura University, and also a senior lecturer at Nottingham Trent University. And today, my lecture is about a bit more educational, more than the research. But I will just touch about my research toward the COVID-19 toward the end of my talk. We will talk about COVID-19, and I think a lot of the audience maybe like to hear about it. And I'll just go through it a little bit, bit by bit. So the COVID-19, it's a disease happened due to the SARS-CoV-2 infection. And the SARS-CoV-2 is coming from severe acute respiratory syndrome, coronavirus 2. And this disease is caused by the virus, is named actually COVID-19. It's coming from coronavirus disease 2019. This is why we called it COVID. It started as an epidemic, and then actually this epidemic started in China and Wuhan, maybe at the end of 2019. That's why, hence the name. And it's in fact actually affecting about 119 million people now everywhere in the world. And those people actually affected with different spectrum of symptoms and signs, but unfortunately we lost about 2.7 million people. This is the most recent statistics from the Johns Hopkins, which I believe that they are fair from this morning. In fact, the death which happened by COVID-19 is happening everywhere. It's not restricted to certain economy or certain part of the world. It's happened actually in the most advanced countries and the European countries more than anywhere in the world. The USA is the most affected country with this disease. This is the most recent statistics from the UK, and it does show that we are lucky that we have 23 million people, more than 23 million people have been taken the vaccine for the COVID-19 now. So we are in a better condition than about 3 months before. And we can see that the curve of the people testing positive, because we have a very good test and trace system in the UK, is going down. And it's going down every week by about 7%. So this is actually okay with us now. And hopefully that will continue like this, because we opened also the universities and schools recently. In Egypt, this is also the statistic from yesterday. The reported cases actually much less than in the UK. Maybe because we only testing the people which are admitted to the hospital and reported officially. However, maybe we have more numbers than these which are reported, because all of the people affected are not actually testing. An irony, only 7 cases reported yesterday in China with 2 billion people, which is something, it's some sort of irony about that the disease started in China and only 7 cases reported now. It's a disease with variable symptoms and signs, but mainly the people are coming with a fever and cough and runny nose. With the new variants appearing recently, we have more with diarrhea and gastrointestinal symptoms. And I believe that this is maybe due to the changes that happen in the virus. However, some people are, most of the people get mild disease, but some of the people get a severe form, which can be fatal sometimes. And if you have been exposed and developed symptoms, follow the quarantine and isolate yourself. This is actually save the people around you. I'll just touch a little bit about this virus. It's a very simple virus. It cannot be simpler than that. Single-stranded RNA virus, about 30 kilobase. It has actually these spikes or arms, which called the spike proteins. That's why, hence the name of the coronavirus. So these spikes are actually very important for the virus to work. And In fact, it is used actually to set on the receptors, which called the ACE2, which present on the almost all of the cells that you have in your body. And that's why it is it's affecting multiple organs, and also it's affecting a lot of the tissues, in particularly not only the lung and the nasal, it's also affecting the ileum. Hence, we have a lot of manifestation everywhere. And that's why it is heterogeneous in its manifestations when it comes to the disease. Well, the immunology part, because I'm an immunologist, I would like to summarize it in simply that you have a simple immune response in which the cells are exposed to the antigen presenting cells, which stimulating the B cells to start producing antibodies, and the T cells to start to be cytotoxic and killing those which are infected with the virus. This is oversimplifying what's happening inside the body, and I'll tell you in a second now. So the immune story, we cannot cut it short, but I wanted to, inspired by the talk of Dr. Mohyiddin Sheikh before, and saying that in the path of the COVID-19, we pass through the innate immunity, and it goes into the adaptive immunity after that. And during this first phase of the first 4 days, we have the dominance of the innate immune system, which formed of the interferons and PDCs and NK cells, which luckily I'm specialized in it. And this is actually govern what's happening after that when the disease progressed toward the adaptive immunity. There was actually a term which came actually recently, and all of the people showed the importance of the pre-existing antibodies, which maybe it's a germline encoded antibodies, which has maybe an importance to show that some people may exist with a certain immunity against COVID-19 from the start, before exposure to the disease. And this is in fact published recently in December, where they showed that some people never been exposed to COVID-19, they do have some antibodies against and some sort of immunity while they have been uninfected completely in their sera against the SARS-CoV-2. However, this needs a further investigation in the Egyptian community. Probably that's what we are going to do soon. Again, the first SARS-CoV-2 epidemic was actually focusing on affecting only adults, but not children. And we tried to explain that a lot by a lot of hypotheses. Some of the hypotheses say that it's maybe because the children, they do have some immunization system which allow them to be much more immune. They have a certain microbiota in their system, maybe protecting them. They have a high level of melatonin, which is associated with the protection against the disease. And believe it or not, that the bats which intermediate hosts for the SARS-CoV-2 are actually having very, very high levels of melatonin. However, these theories start to fade a little bit when we have the new versions of COVID-19, because we have new strains now which affect equally the adults and children. And maybe because of the ACE2 attachment is much stronger in the new variants than before. I want to summarize something for you, which I want you to remember, that the pathogenesis of the COVID-19 either taking the good or the bad pathway. If it's going to the bad pathway, in summary, there is a defective immune response happen, and this is the cause of the aggravation of the moderate to severe cases that you see. And this is mainly due to the presence of some non-neutralizing antibody formed. So in the second phase, when they're having the antibodies here formed, it doesn't mean that all of the antibodies are protective. Some of the antibodies can be actually an adverse and help the virus to be intaked by the cells. And beside that cytokine storm that may happen, all of these are indicating that there is an uncontrolled immune response, and this uncontrolled immune response may go into the dysfunctional pathway, and this is why we see excessive infiltration of monocytes and macrophages in the lungs or in the tissues, and systemic cytokine storming and pulmonary edema. And usually this is the cause of death if you are in, if somebody, sorry, in the acute phase of the disease. However, the good pathway is that we have a healthy immune response in which we have a good amount of neutralizing antibodies, which help to neutralize the virus. And we have actually a good synchronization between the alveolar macrophages, which recognize the disease and starting asking for healthy interaction from the immune adaptive system and what we call the controlling the COVID-19 in the right phase or the right way. COVID-19 is linked all of the time with the pathology of the immunothromboembolism, and this has happened due to activation of the extrinsic and intrinsic coagulation pathways, and this has happened due to the immune aggravation. I can consider it as a form of a parallel to the cytokine storm that you see it in the pulmonary edema and the pulmonary affection when it's happened that way. And these thromboembolism, that's why in our country, in Egypt, they actually follow the people by looking for the D-dimers, platelets, and the clots degradation as some sort of indications of the progression of the disease and indication what's happened in the alveoli with the, because we cannot do a CT every day. Yeah, it can be diagnosed by the CT scan, but the follow-up needs actually some laboratory interpretation. Until now, we don't have a gold standard on giving therapies for COVID-19. However, we've learned a lot in the last year, and there are some drugs which show actually some impact, like this tocilizumab, which antagonize the IL-6 and prevent the pulmonary edema and decrease the time for the people in the lucky people in the ICU if they are infected and they got actually a severe infection. And at the beginning, we've been talking about hydroxychloroquine. We have been talking about a lot of other drugs like remdesivir as a drug. But I have to say that treatment of COVID-19 is a combination of everything. It depends on the decision of the clinician at the situation of the patient, and they try actually all of the battery. But dexamethasone and tocilizumab, you will hear about them a lot in the treatment of this disease. And some antibiotics are used also, but it's for it's a secondary effect, not for the primary effect. What is the good about that? That most of the patients go asymptomatic or pre-asymptomatic infections, and 50% about of the cases like that can be up to 80% in certain populations. And this is accidentally discovered, and you discover it when the people traveling abroad and they do the PCR and they found that they are positive and don't have any symptoms or any signs. So, but some of the symptomatized people, I have to say 80% of the symptomatized, the other half, is actually happening as a mild or moderate disease. Not the severe is very low in comparison to what we hear about it, but because it's affecting millions of people, this low disease percentage, either critical or severe, is about 10% of the population or to 20% maximum. Can we get a lasting immunity with COVID-19? In short term, I would say no. The COVID-19 itself doesn't give you a lasting immunity. You may get actually some antibodies, but to get the lasting immunity, you have to get the vaccination. And this is actually proved by the reinfection, which happened to the people by the SARS-CoV-2 up to 3 times in 1 year. Recently, also, we discovered new variants, and I'll talk about this variant, which expanded by the end of last December, which they called it the Kent variant, because it is discovered in the UK, and it was responsible for the shooting which happened in the third wave that happened in the UK, and this is maybe the cause of the all of the lockdowns that happen in the UK too. And this has happened due to they put this hypothesis that some of the patients that they acquired the virus and they stayed inside the body for a long time. This is a Gupta paper, which is produced to everyone by January, and in which they showed that there's some patients have been trying to be treated, and they did actually collected some samples from them. And every time that they get the sample, because he got the convalescent plasma, he got actually a new mutation. So they come out with the theory that the convalescent plasmas maybe shouldn't be the first line of therapy for the people, because it may enhance the mutations of the viruses in the immune compromised patients. So I have to say that sometimes this has happened, and maybe this is indicate why COVID-19 keep mutating and motivating. I want to indicate for you what's meaning of long COVID. And now everybody's talking about long COVID. It's a long-term effects of coronavirus, because a lot of people now recovering. And we notice that there is a percentage, I have to say, some people say 20%, some people say 10%, which they may have more symptoms and staying after 12 weeks of infection. And I have to say and warn the people that the mild symptoms people also can develop a long COVID. So it is not only restricted to the moderate and severe people. And that's why the vaccination is more indicated. These long COVID patients can be coming by anything of this spectrum of extreme tiredness, short of breath. It's usually affecting these organs, which are actually heavily having ACE2. So it is the nervous system, the lungs, and the cardiac, or maybe also the musculoskeletal system. And usually the symptoms are not, the people just say, I'm not right, I'm not the same. Very rare to find the people feverish for a long time, but usually they come with all of these spectrum of things, which they actually, NHS in the UK, restricted to this list of things which can happen. So how we can do and manage those people are sent again for investigation and thorough investigation of everything and functional assays. They look for all of their history again, and they do some blood tests to look for all of the functions of the body, in particularly those which having symptoms of 3 or more weeks. So they now actually shorten the long COVID. If you have symptoms after 3 weeks of what we call recovery, you may have to consider yourself as a long COVID. And it's really crippling because it is affecting all of the organs. And we say that it needs a little bit of medical management if you cannot do the self-management for that. After advising of rest and relaxation and self-spacing and a gradual increase of the exercise with a certain tolerance, we have now clinics which called the long COVID clinics to monitor these patients longitudinally. Vaccination made big change in this history, on this story. However, not all of the countries in the world are giving the vaccine equally. So some of them, they just restricted in one group, and some of them in 2 groups. Very rare that you find maybe one country in the world which give it universal to all of the people, maybe because of population thing. Some people like UK and Saudi Arabia now, they are just giving to the vulnerable and some other people. So don't be surprised that they are not providing this vaccine to everyone walking in the street. And the vaccines that we have a very wide spectrum, starting from these inactivated vaccines, the famous Sinopharm one, and other types also. And we have the live attenuated vaccines, but they are not very famous. The more famous now is the recombinant spike protein based vaccines like Novavax, which just recently approved in the UK. And we have other forms of vaccine which using viral-like particles, and they are just these viral-like particles, they are just covered with the spike proteins. The most famous ones, Pfizer and Moderna, are the RNA vaccines, which they use the RNA encoding the spike protein and typically packaged into like a sellotape into these LNPs. And I have to say that the spectrum is wide because we haven't been sure which one would be more effective for disease. The most famous now is the category of the replication incompetent vectors, which looks like Janssen, Sputnik, AstraZeneca, and CanSino Bio. All of these are using certain viruses, which are viral vectors, which incompetent vectors, and these are actually loaded with the encoding of the spike proteins and giving to the patient. And we are expecting that will continue in a better way. And the advantage of this system than the other system, I will mention it in a second. We have also inactivated viruses, and we have the DNA vaccines, and we have also the Merck vaccine, which use replication competent vector, which can replicate, in fact, inside the body of the patients. A lot of them have been approved in the UK, and UK usually the first one to approve. Then after that, the European Union Medical Association approve it, EMA. Then after that, also the United States. It's maybe because we are keen more on this. I'm very glad that in Egypt now we are actually vaccinating the people with multiple forms, and I have to say that we did choose the best. And there are advantages and disadvantages, but Sinopharm, Sputnik, and AstraZeneca are one of the best. One of the best, I would say that it just gives the immunity that we are looking for by the antibodies and the T-cell immunity, in particularly for those which are vector-based like Sputnik and also AstraZeneca Oxford. Why we have all of this variety? Because roughly 7% of the vaccines in the preclinical studies goes to actually the final stage. So we have to start with hundreds, and we end up with few at the end. And the candidates of these genes are 20% chance to succeed, to be honest. And very few actually are able to scale up unless it is supported by big companies and big pharma factories, which can produce millions of doses for these vaccines. In fact, in the UK, they actually contracted for 357 million doses of these vaccines, and which is maybe triple of the number of the population or the quadruple of the number of population in the UK. And each one by one are licensed, and we have plenty of them now. And we started vaccination on the 8th of December, and we have now 23 million people, or more than 23 million people vaccinated, with average of about 350,000 people every day vaccinated. Do we expect adverse effects from vaccines? 1 in 10, they get some minor abnormalities like myalgia, headache, fatigue. But this is not only the ones, some rare things have been reported. But we have here a strict system in the UK called the yellow card schemes. And I will show you what is the importance of this. The yellow card schemes is equal to the system in the US, which is called the VAERS. And these schemes are actually for reporting the adverse reaction when you start using a drug or a vaccination for millions of people. And this is to report it by the medicals and also by the people. So you can report it about yourself if something rare. And I have to say that recently I've heard that some of the vaccines is making some thromboembolism. In February, they've been showing that Moderna may be actually having some blood problems with some people, but these are very sporadic cases. And yesterday, they just announced that in the yellow cards that only 15 thromboembolism reported from Pfizer and 12 only reported from Oxford AstraZeneca. This is if we consider 23 million people have been vaccinated, considered very, very rare. So I would say that it is safe to take these vaccines and don't worry about it because it is not attributed and not linked with the vaccine itself. I'll just jump on what I'm doing on the COVID-19 research. I joined actually the COVID-19 host genetics initiative, and I created the with a lot of colleagues in Egypt, what we call the Egypt Hub for genetics. And we joined this COVID-19 genetics initiative to find the relationship between the genetics of the people and the severity of the disease. And we collected up till now about more than 2.1 million genotype people, and this is actually very large number in considering that we are testing only at the moment 50,000 COVID-19 patients. And our first results, which is still unpublished, I will just show it to you, that we try to attribute certain risk factors and associated with the studies may not point to the causal of the COVID-19. So for example, we found that the BMI may be associated with the Mendelian randomization and also with the genetic correlation, but this is actually a very broad term. When we did a lot of the meta-analysis, I have to say the preliminary results of these millions of cases showed the first round, some certain genes and some certain peaks show a certain association with the COVID-19 in the critically ill patients, but I'm not allowed to talk about it so much because it's still in publication. I have to say that I'm very proud that we are the only group in Africa, in Egypt, which are sharing into this very big study, which has 49 countries contributing with 147 studies, and we are making a contribution toward that, and I'm honored to be a leadership on that. And we got also an Easy Genomics funding to continue on this research. Our results will be published soon, maybe by June, in Nature, and we have actually a virgin type of publication that every accumulation or freeze of data, we will publish another version of the same paper. So this is a new form of publications. I would just recommend everybody to follow the instructions to protect you and to avoid the transmission of the disease by applying all of these things, mainly the masks and the social distance are making a difference. And please vaccinate for COVID-19 because it is safe and it is protecting you from going into long COVID, I have to say.